Hello, and thank you for downloading this programme, which was first broadcast on the 9th of August 2016. Coming up today, Through the Keyhole, we visit one of a growing number of centres in the UK pioneering a new approach for a common hip problem.
If I hadn't got up and moved around for maybe 40 minutes, 45 minutes, as soon as I would go to stand from my chair, it would be like slow motion to try and get up. You'd almost be pushing your hands off the desk to stand up and move away. And as you walked away, you'd almost walk away hobbling to get away and to move the legs.
And treating cancer. There's an ever-growing range of new therapies to choose from, and more people than ever are living with the disease. But just because we can doesn't always mean we should.
The difficulty is that we know for a fact that we're all mortal. And so how one tempers that therapeutic momentum, for want of a better word, the ability to give more and more, against the fact that all of us must die, and therefore the ethics of balancing a good death or a good last 6 months or year of life, I think is really hard.
But first, the Zika virus, which has had more than its fair share of coverage this year, albeit mostly stemming from cases in countries far from our shores. Not anymore. There have now been over 50 confirmed cases here in the UK, with the latest reported just last week in Scotland. Dr. Margaret McCartney is in our Glasgow studio. Just to be clear, Margaret, these are imported cases where people have picked up the virus abroad rather than catching it here in the UK.
That's completely correct, and I think some of the press coverage has been a wee bit misleading in that it's kind of saying that there are new Scottish cases of Zika virus. These are people who have been to a country which has the infection and have imported it back with them.
Has the news in Scotland prompted any concern?
There's certainly a lot of chat about it, and I think a lot of people are quite concerned, what should I do if, and are looking to see which countries are affected. But really, this is not a virus that's indigenous to Europe. This is still a virus that's going on in Central and Southern America, in the Caribbean and Oceania. It's not something that's indigenous to the UK. It can only be spread by human sexual contact. It's very, very rare to have human-to-human transmission. Otherwise, it's spread by mosquitoes, and those mosquitoes simply cannot survive in the UK.
What's the situation now globally?
Well, I think there's still a great deal of concern, and there's still lots of information available on the websites, the government websites, advising really pregnant women not to make non-essential travel to countries which have the infection ongoing. And if women are going to these countries and thinking of becoming pregnant, to be very cautious in terms of protecting themselves against mosquito bites and not getting pregnant for at least 2 months afterwards, 6 months if they think they may have been infected by the virus at that time.
Thank you for now, Margaret, and there are links to more information on Zika, including travel advice, on the InsideHealth page of the Radio 4 website. Now, I'm sure most of you will be familiar with arthritis of the hip and surgery to replace the joint, but I bet you're not so familiar with hip impingement, another common cause of hip pain, and one that's thought to increase the odds of arthritis later in life. And what about hip arthroscopy? Keyhole surgery to repair damaged knees has been around for decades, but have you ever heard of anyone having it done on their hips? Probably not, but all that could change thanks to a growing awareness of the problems caused by hip impingement and growing evidence that hip arthroscopy is an effective way of treating it. NICE endorses this type of surgery on the NHS, but advises that it should only be carried out by surgeons with a special interest in hip arthroscopy, and they're still thin on the ground in the UK. Sean Glyn-Jones, Professor of Orthopaedic Surgery at the University of Oxford, is one of them. So, to learn more about the technique, I caught up with him in the outpatients department of the Nuffield Orthopaedic Centre.
The clinic you're in at the moment is the young adult hip clinic, and it's a slight misnomer in that we cover a broad range of ages, but typically people with earlier stage arthritis and hip pain rather than late stage arthritis and hip pain needing hip replacement. And so we typically see patients from both our own region, but also commonly from around the country, even from other countries, and we have service agreements with Malta and Cyprus and various other parts of the European Union.
What sort of procedures are you using it for?
The majority of the time we would use it for two main pathologies, and they're kind of interlinked. The first is a condition as a labral tear, which is a rubbery piece of cartilage that goes around the rim of the socket of the hip, and that can sometimes become detached, and we can treat that usually by repairing it, removing it, and in some cases people are now reconstructing it. The other type of pathology we would be treating in the hip is a condition known as femoroacetabular impingement. Rather long-winded name, I'm afraid, but it's a condition where there is an abnormal bump on the front of the hip joint or a deep socket that causes bits of bone to bang together in different positions, particularly when people are squatting or sitting. And in those conditions, we can then reshape the hip using keyhole surgery to reduce the chance of those pieces of bone hitting together. But those two conditions are quite interlinked, so a femoroacetabular impingement can give you a labral tear, and quite often does. But in other circumstances, labral tears can be due to trauma or even just the body wearing out with age.
I don't want to date myself, but when I was at medical school and working in hospital, I never heard those terms, and yet I hear them a lot now. What's changed?
Well, I suppose it's an awareness of the condition and an understanding that the pathology exists. And I suppose in the past people would have presented quite often to surgeons and their general practitioners with groin pain and may have been told they had a strain or maybe a small hernia. And now we understand that a lot of those patients had problems inside the hip joint that wouldn't necessarily have shown up on X-ray.
So what's the classic story? How are these patients presenting?
So the classic story is usually someone in their 20s or 30s that presents with intermittent groin pain. Initially the pain is often what we call positional, that is you put your hip in a certain position, typically bending the hip up or dropping the knee out at the same time, and that will give you reproducible groin pain. Over time, you can have other sets of muscle dysfunction associated with that can lead to more generalised pain. But in the early part of the presentation of the condition, it's often very focused in the groin, sometimes the buttock.
Professor Glyn Jones lets me sit in on his next consultation. Amanda has already had an arthroscopy on her left hip and has now come back to clinic with problems on the other side.
Nice to see you, and thanks very much for coming up to see us today. Obviously, you've had the left side done. You had an operation, a keyhole on that a while back. So just quickly remind me how the left one's been going and how the right one's been doing.
Well, the left one you did for me in September, and since then it's been absolutely perfect, and I wish I'd had it done 5 years previously when they first decided it.
So just remind me how long it was going on the left side before you ended up with the diagnosis and before you ended up coming to see me.
I suspect I probably suffered for about 3 years, and then I waited 5 years with no funding to have it done, and then I was referred to you.
So that's about 8 years really from when you had to start pain. So you had quite a bit of pain, I seem to recall, when you first came to me. And in terms of how that compares with the right side now, is the right side at an earlier stage a bit less painful than the left side was?
I would say at an earlier stage, but I would say I have the pain, I have the limitation in terms of movement.
Amanda has been affected by the pain in her left hip for years, and it's intruded on almost every aspect of her life.
If I was sitting at work and I'd been working away at my computer at the desk, if I hadn't got up and moved around for maybe 40 minutes, 45 minutes, as soon as I would go to stand from my chair, it would be like slow motion to try and get up. You'd almost be pushing your hands off the desk to stand up and move away. And as you walked away, you'd almost walk away hobbling to get away and to move the legs.
And that was because the hip was painful?
Painful and very stiff and very sore. Describe it as a constant soreness.
And where were you actually feeling it?
Everywhere from my hip all the way down to, I would say, my calf, my ankle. It was extremely wearing. It would wear you down.
So what treatment were you offered?
None. There was no money available, full stop. The only money available was to have a full hip replacement, and the surgeon's hands were tied.
So they were offering you at that stage to do nothing other than physiotherapy or a full hip replacement?
At the time, with that surgeon and within that hospital environment and that hospital trust, they didn't have the money to fund the hip impingement, so you had to wait until you were at the point that you needed the full hip, and there was nothing the surgeon could do. His hands were tied.
Seems a bit daft, that, doesn't it?
Totally.
That you have to wait till it's bad enough for a full replacement.
I think it's crazy. I mean, I'm 46 years of age. To think that I would have to wait on my full hip and to have that degeneration in my quality of life and everything that I did, it would have limited my job, it would have limited the capacity of what I could do.
Who gets these problems?
Well, it's interesting. It's quite a broad spectrum of people, actually. Most of the time, you're talking about people in their 20s, 30s and 40s. But we do see people with labral tears in their 70s. And, of course, the older you get, the more likely you are to have some arthritis creeping in. And we know that the more arthritis there is in your hip, the less well you're going to do with keyhole.
So what was happening to these people before we realised how significant the condition was? I mean, if you leave this, what happens to the hip other than daily pain?
To answer the first part of your question, many of these patients are treated very well with physiotherapy and have a very good levels of function and are able to return to sport and exercise. Subsequently, we've now understood the condition a bit more, and there are a group of patients who don't progress after physiotherapy, and in those, they would then expect to see them in an orthopaedic clinic to discuss the options for things like surgery.
You eventually got your arthroscopy. What was it like afterwards? How did you feel immediately after the surgery?
Astonishingly good, even though I'd been through surgery. I came in the morning, had the surgery during the day, and I was discharged the following day on crutches. The pain that I had been suffering for solidly five years for sure in the left leg had instantly gone.
So you knew you were better?
Yeah.
What do you tell your patients about likely outcomes?
We know from a wealth of data, there are hundreds of papers now on keyhole surgery of the hip, and we know that about 70 to 80% of people who have keyhole surgery will see improvement. About 30% do not, and within those, a proportion of those get worse. And the majority of those who get worse will tend to be patients with arthritis. And so the data is not conclusive by any means at the moment, and things are still evolving because it's a relatively new area, but the community has taken great care and responsibility to set up what we call randomised trials to try and test the hip arthroscopy against the next best treatment we have, which is physiotherapy. There are 2 ongoing in the UK at the moment. There is another 2 or 3 ongoing around the world. So we will have more information on both outcome and who specifically we should select for surgery in greater detail over the next 5 years or so. You realise that with the left one, when we did the surgery, there was a bit of arthritis there, but we repaired the labrum, we took the bump away, which we think was the cause of that arthritis, and we also needed to do some regenerative procedure known as microfracture to try and get the cartilage to grow back, and it would seem, at the moment, successful so far. Hopefully on the right-hand side, we will have caught things a bit earlier, so hopefully we will find less damage on the right-hand side, but just need therefore to be treating the bump at the front of the hip joint, but also the tear in the cartilage as well. So, Amanda, thanks very much for coming up all the way to see us today, and I look forward to seeing you in 2 weeks' time for your surgery.
Yeah, can't wait. That's a random thing to say, but for having surgery, but I can't wait. Thank you.
Thank you.
Amanda and Professor Sean Glyn-Jones talking to me at the Nuffield Orthopaedic Centre in Oxford, and there are some useful links on arthroscopy for hip impingement on our website, where you'll also find details of how to get in touch. Millie Keeve tweeted to ask me why we didn't plug the yellow card system for reporting side effects in last week's item on statins. Perhaps if more patients reported problems, they might be taken more seriously. Well, Margaret McCartney's still in our Glasgow studio. Margaret, perhaps you could start by explaining what the yellow card system is.
Yeah, we have talked about the yellow card system before on Inside Health, and I'm a big fan of it. Essentially, it's a mechanism to report suspected drug side effects to the Medicines and Healthcare Regulatory Authority. And it used to be that only doctors could do it with a bit of yellow cardboard that was literally pasted into the back of the British National Formulary, which is the big drugs book that we all use and refer to get information about prescribable drugs. And you had to rip that yellow card out, fill in the details and post it to the MHRA. And I was always very proud of myself for doing this. I considered myself quite diligent in doing this, but it's so much easier now. You can do it online, you can do it from an app. And really importantly, it's not just health professionals that can fill these in, it is anybody. So you can decide to fill in a report yourself, and I would encourage you to do so.
Does patient reporting help? Do we have any evidence of the impact of patient reporting?
That's a good question, and lots of people I think are a bit concerned that perhaps we're not using this information well enough, but any information is only as good as it is. So if you've got lots of people that are engaged in sending in high quality reports and information about drugs, then that's obviously much better than a system where very few people are sending it in. Of course, we still do need really big randomised controlled trials that are going on and looking really hard for unexpected side effects, so that still needs to go on. But what the yellow card is really useful for is for the far rarer really unexpected side effects that perhaps would have been missed in small trials. If you've got a side effect that only turns up in 1 in 10,000 people, you have to have trials that big to start to find potential side effects. And of course, once that drug has been used by thousands more or millions of people, then you can really start to pick up much rarer side effects in quantity. So I would encourage people to fill it in and get the app or go to the website. If you just Google yellow card, you will find it, because the information is looked at and it is incorporated into making making decisions about what side effects are listed in these drugs in future.
Obviously, severe side effects are important, but do the authorities particularly want to hear about newer drugs too?
Yeah, so there's a special system where drugs that are more recently on the market are kind of prioritised within that system to get really thoroughly looked at, and doctors are extra encouraged to report side effects from them.
Another listener contacted the BBC to complain that the chair of the British Medical Association was not the right person to present Inside Health, as his interests were too conflicted to be impartial. Well, I'm sure that would be the case. Fortunately, I'm nothing to do with the BMA. That is another Dr. Mark Porter. Confusing, I know, but not as confusing as the time I once interviewed him here on Inside Health. Dr. Mark Porter talking to Dr. Mark Porter. I wonder if the comedian and broadcaster Dr. Phil Hammond gets confused with the Chancellor and receives complaints that he's not ideally placed to draw up the nation's budget. And I mention Phil, Margaret, because a little bird tells me you're moonlighting with him at the Edinburgh Fringe.
It's a bit crazy, but yes, that's what I'm doing. So every night until the 27th of this month, I'm doing a little guest spot on Dr. Phil's comedy show. He's doing the funny stuff and I'm doing statistics and evidence-based policy making.
Well, I wish you luck in your newfound career as a stooge, Margaret. Those Edinburgh audiences can be tough. Now, at Inside Health, we often concentrate on hard, quantifiable measures like data from randomised controlled clinical trials. But medicine has a softer side too, particularly when it comes to treating complex conditions like cancer. More people than ever in the UK are now surviving or living with cancer thanks to recent advances in treatment. But choosing the best approach can be difficult. Advising someone with an early bowel cancer to have surgery where cure rates approach 100% is much easier than choosing the best treatment to extend the life of someone with incurable lung cancer, or recommending aggressive chemotherapy for a hard-to-treat tumour where there's only a slim chance of a cure. Just because we can doesn't mean we should, a quandary compounded by the speed of development in the cancer field. Sam Guglani is consultant oncologist at Cheltenham General Hospital, where I refer many of my patients with cancer.
I've been working as a consultant oncologist for 10 years, and it's visible, it's palpable, that shift, that gathering of evidence, even over that short period. So what I was doing to look after patients with breast cancer a decade ago is profoundly different now. The armoury of drugs, for want of a better word, using that common metaphor, is much wider. So where previously we might have said, look, we've now tried 2 or 3 drugs, chemotherapeutic drugs or otherwise in sequence, there are no further therapeutic options. That is no longer true. And that is something that's applauded very much by society and by health professionals. You often hear the accolade, exciting new data, because there are undoubtedly benefits. Response rates, as we call them in medicine, i.e. if I gave that drug to 10 patients, 3 of those patients would see a shrinkage of their cancer, a 30% response rate. Progression-free survival, i.e. the tumour stays quieter or in remission for longer, and indeed overall survival. Increase in length of life by months, sometimes indeed by longer than that.
But is it generally the law of diminishing returns? I mean, the more treatment you're adding on, the extra layers that you're adding in here. I mean, a lot of these people are quite ill. Are you getting a good return? I mean, from the patient's point of view,
Yes.
I'm talking about resources here.
The easy answer to that, the almost caricatured, stereotyped answer is no, drugs are bad. Look at the terrible side effects that we can cause. However, I'd be lying if I said that was true. So in fact, if we look particularly in the modern era of personalised or targeted therapies, where we're really defining the genetic signature of a tumour, for instance, and being able to target it with drugs that yield higher response rates at lower side effects, then that is a good thing. The difficulty is, and this is a real difficulty, is that we know for a fact that we're all mortal. And so how one tempers that therapeutic momentum, for want of a better word, the ability to give more and more, against the fact that all of us must die, and therefore the ethics of balancing a good death or a good last 6 months or year of life against not just the side effects of treatments, but all that it means to be visiting hospital every 3 weeks, having blood tests, having scans, all the fear and anxiety that comes with that, I think is really hard to put on some kind of mathematical scale.
Let's take cost out of the equation, because many of these new treatments are very expensive and not all are freely available.
Sure.
And let's just talk about what's right for the patient. Now, no two cancers are the same, no two patients are the same. So how do you and the patient decide what level of treatment is appropriate? How do you have this conversation, and what sort of factors are influencing that conversation?
Yeah, I think that's a really interesting and important question. And if we take a very crude description of medical ethics, one of the key things that we're encouraged to foster is an individual's autonomy, their right to self-determination, to be able to choose what's right and wrong for them. And arguably, to be able to do that well means in some fashion really hearing the person in front of you, empathizing with them, identifying with them, and getting a sense of what is important for them. What is it that's important to you? Now, these are rarely mutually exclusive, but might find themselves on a scale of, on the one hand, prolonging life at all costs, and at the other, of really trying to focus on life quality as a primary outcome. The difficulty is, of course, they merge, and even with the wish to prolong life at all costs, there are limits to what medicines can achieve. Now, that's really hard to communicate, because all the time the media is keen to champion and celebrate scientific advance. How does one make that decision in the consultation? I think the interesting thing is that doctors come to this encounter with as many biases, beliefs, subjective values, fears, indeed, as a patient. I mean, Henry Marsh wrote about this really well in his recent book, Do No Harm, but how much fear there is about, if I don't do it, what if, I might have missed a therapeutic benefit. Similarly, though, I might come to an encounter with a patient and wonder about the pros and cons of chemotherapy for, let's say, someone who has a brain tumour. And very present in my mind will be a similar patient who I've just given that treatment to, who's on the ward suffering terribly with side effects, or indeed worse, which will, outside of the evidence and the p-values and the statistics, really inform and be present in my views and what I try and communicate there. And if I may, just very quickly, a really interesting thing that we've often commented on is, let's say there are 5 or 6 oncologists in the organisation where I work, all treating breast cancer, and the same patient with exactly the same scan and facts of the case, for want of a better word, arrives at a consultation with all 6 of us. They will come away with a different sense of what the right thing to do is, based, one has to assume, primarily on differing people's interpretation of the same facts, what they prize and value as good medicine.
So what you're saying is that there's a little bit more to this than science and evidence. There's a touch of art.
I suppose I'm saying that the scientific method and evidence-based p-values, confidence intervals, will take us so far and have taken us leagues into bettering what we can do. But there are other forms of knowledge. That's not to in any way diminish the scientific method and all of that, but to applaud it. But there are, perhaps, they're finally not sufficient for our encounters with the sick. That we need self-knowledge, not a little humility, ethical reflection, things that might find their way into a definition of wisdom are important. How one fosters that, or cultivates it, or indeed recruits for it, I think is a really difficult thing. But we'd be kidding ourselves, indeed we do kid ourselves every day in medicine, by not admitting to the fact that we bring to the clinical encounter our own subjective views, beliefs and hopes. And I think a bit of self-knowledge around those will take us a long way into caring better for our patients.
The patient will come to your consultation with their own ideas. One of the first things that my patients tend to do is they or their family, they Google their condition, they find out what the latest treatment is, and they want everything done, understandably.
Yes.
Is that a common scenario when in the early stages?
People do vary wildly, as they do when they're well, with how they receive and then contend with falling ill. But I think there is a problem, and others have written about this very well, most recently Atul Gawande. There is a problem, I think, with how we as a society, and I count health professionals as part of that society, really authentically encounter and meet the fact of our mortality, unless we're suggesting that modern medicine will, in the next 50 years or so, 100 years, indefinitely prolong life, and that seems unlikely, then we're always going to be faced with just that ethical question. To what extent do we pursue with active intervention if someone has 6 months or a year to live, and at what cost to them?
Do many people change their minds as they're going
Yes.
along this journey of therapy?
Yeah, very much. Personally, I think that's fine. Medicine's very bad at contending with uncertainty, and that's a form of it, because what one might say is there may well be benefits here. It's important to you to try and fight it. Similarly, and again, that metaphor, fight it, the military metaphors creep in. Important to you to fight it, but equally there are side effects here. It would be a reasonable thing to try this and see how things unfold, with the view that if it isn't helping, or if indeed it's causing more harm than good, one ought to rethink. But you can only do that if you're truthful at the outset about what you're setting out to do, i.e. to prolong good quality life.
Do you come across many patients who are scared of being perhaps seen to give up?
Yeah.
I mean, give up in the eyes of other people. They've made what might be a very sensible decision, but they're not having treatment. They're under pressure to have that treatment from others, or society maybe.
I think the giving up thing's interesting, and I think the fear of giving up, what I might just rephrase as a fear of seeming nihilistic, happens on both sides. So if we think about the very common refrain you'll hear on the 10 o'clock news, UK figures lag behind North America, Europe, the charge there is one of being nihilistic in this country, and it's a charge that doctors get really uncomfortable about, because it's seen almost as being counter to good medicine. You're not being macho enough. Never mind the fact that for a good 2 or 3 decades here, our approach to palliative care and the fact we can deliver that synchronously with active treatment has been second to none. But I think that then also mirrors on the other side of the consultation room desk, where to be seen not to fight, in inverted commas, it almost is a non-starter. It's not perhaps even almost British, which is an interesting thing. And it's okay to want to live. It's a good thing to prize life and to hope to live. It would be an odd world where one diminished the value of life. It's a centrally valuable, important thing. But the truth of it is that it will end.
Oncologist Sam Guglani from Cheltenham General Hospital in reflective mood and giving us all something to think about. This is the last in the current series of Inside Health. We'll be back for another run in the middle of September, and as always, are keen to hear your ideas as to what items we should be covering. So if you have something you'd like us to investigate, then please do get in touch. You can email insidehealth@bbc.co.uk or tweet at Dr. Mark Porter. Until next time, goodbye. Make sure you don't miss an episode by subscribing to the automatic podcast service if you haven't already. Details on the Inside Health page of the BBC Radio 4 website.